A very good morning to you, our viewers. I'm your online host, Edmund. Welcome to day 3, which is the final day of the SATA ComHealth Osteoporosis and Fall Prevention Festival. Falls are a common cause of injuries among older adults, and the incidence of falls increases sharply with age. The good news is that falls are preventable through clinical interventions and reducing risk factors. We will hear from more of our distinguished panel of speakers over the next 6 hours about a host of related topics. To kick off today's program, we have with us the first of our distinguished panelists, Dr. Anandakumar Vellasamy. He is a Swiss fellowship-trained, board-certified orthopedic foot and ankle surgeon. He currently practices at the Center for Orthopaedics Group, with clinics in Mount Elizabeth Novena, Farrer Park, and Parkway East hospitals. Dr. Ananda has an interest and expertise in complex adult foot and ankle sports and trauma surgery. Kindly note that questions will only be addressed by the speaker at the end of his talk. Please utilize the built-in Q&A function to pose your questions. Dr. Anandakumar will now speak to us on foot problems in the elderly.
Okay, thank you, Edmund, for the warm introduction. It's my pleasure to be here in the Osteoporosis and Fall Prevention Festival and to discuss about some topics that are quite close to my heart as a foot and ankle specialist. Thank you for also joining us on a Sunday morning, putting aside your recreational activities and taking the time for some knowledge gathering that hopefully can lead to better health. Okay, so without further ado, I will start my talk. Let me share my screen. Okay, so the title of our talk today is My Feet Hurts. Without further ado, I'll just give a brief introduction about myself. So essentially, I'm a Singapore and Swiss fellowship trained foot and ankle surgeon, but I also deal with general orthopedics and trauma surgery. And as you know, osteoporosis is a common cause for falls, and trauma need not necessarily be just on the foot and ankle, but it can also affect other areas such as the hip, knees, lower limbs, upper limbs. So it is important to understand that, general prevention of osteoporosis is extremely important to prevent orthopedic complications, essentially. So without further ado, talking about the foot and ankle, I just want to highlight that the foot and ankle is actually only part of what we call the axial skeleton, because we actually stand upright as human beings, and the weight of our body is borne on both the hip, knees, and ankles. So a proper alignment is essential, essentially, to prevent problems of the foot and ankle. And it is not uncommon that sometimes if there is a misalignment because of some knee issues or hip issues, sometimes the pain can be manifested in the foot and ankle as well. So it is important as when we see our patients to actually make sure that also the knee and the hips are well aligned. As you can see in this the scheme at the top, some patients have a very natural posture or alignment, but we also do have patients who sometimes have bow legs or knock knees. And it is not uncommon that patients with bow legs and knock knees may not have pain in the knee sometimes, but actually they have pain in the ankle and the foot. But the problem is actually from the knees, and correcting the knees or the alignment of the knees can actually help to solve the foot and ankle problem, essentially. So it is important that when we see patients with foot and ankle complaints, that we look at it holistically as an individual, as an alignment of the entire structure, skeletal structure. Coming on to the foot and ankle proper, as you can see, the foot and ankle is composed of several joints and several bones as well. And you can see that above and surrounding these bones and joints, there are also many small muscles and tendons and ligaments. One fortunate thing about the foot and ankle is that very commonly, whenever patients complain of pain at some area of the foot, it is quite common that the pain at that particular localized area of the foot is highly likely to be related with the anatomical structure that is present there, because the foot and ankle is such a small space and there isn't much like subcutaneous fat in these areas. So essentially, when there's a joint problem or a bone problem or a tendon problem, the area of the skin where the patient complains of pain usually correlates quite accurately with the structure that actually lies there. So it actually makes diagnosis easier, but at the same time, sometimes it is important to do further investigations like X-rays or even MRI scans to actually determine if the problem is actually from the bones, or is it from the joints, or is it from the muscles, or is from the tendons, because there are all these structures that are there. And some considerations that we need to take note of, especially when we see patients who are a bit more elderly, is the understanding that our skeletal structure changes over time. And one of the more common things that we tend to note is that as we grow older, we actually lose collagen type 1 fibers. And collagen type 1 fibers are found throughout the entire skeletal structure, muscles, tendons. And what exactly happens when you lose collagen type 1 fibers is that we actually lose some flexibility. So it is not uncommon that sometimes our joints feel stiffer, our muscles feel a bit more stiffer compared to, when we were younger, perhaps. But what is important to know is that we can actually help to delay the loss of these collagen type 1 fibers with proper exercise, stretching, and this will go a long way in preventing the gradual loss of these collagen type 1 fibers. And that is the reason why we always advise elderly patients to actually, do some gym work or some weight training, because we want to actually slow down this loss of muscle mass. And it's also important to slow this loss of muscle mass because we do know that, for example, osteoporosis, one of the risk factors for fractures because of osteoporosis, because of a very thin or frail patient. And this usually is because there's a loss of muscle mass, and therefore there's less cushion, especially when they have a fall, and it's easier to injure and get a fracture in that sense. The second thing, as we are talking about osteoporosis, is the understanding that our bone mineral density as well declines as we age. The bone, within the bone itself, is the marrow, and the marrow is filled with bone tissue, and this bone tissue becomes less dense as we grow older, and therefore it becomes more susceptible to fractures because it's actually structurally weaker in a sense. And not to mention, when we talk about joints, there is also cartilage thinning and wear because of the amount of activities that we do throughout our life. There are many cycles of knee movement, ankle movements, and this actually leads to slow wear and tear as time goes on, and that can lead to cartilage thinning, and this can lead to problems like pain, joint swellings as well. And the other thing to take note of is shoe wear modifications. So it is very common that, as I was mentioning previously, because of the fact that we do lose muscle mass, we do lose collagen type 1 fibers as we grow older, sometimes our skeletal structure, especially in the foot and ankle, can change. So you may not have flat foot, for example, when you were younger, but you may actually develop flat foot when you actually grow older. And that's because you have lost some of this muscle tone, and therefore your foot tends to have a collapsed arch in a sense. Accordingly, it's important to note this and change our shoe wear as well, because if we continue to sometimes wear ill-fitting shoe wear, this can lead to further problems, pain as well. So these are some considerations to take note of when it comes to foot and ankle bony architecture. And the other thing that elderly patients tend to have is because of skin dryness. There can be easier cracked skin or damaged skin. And these cracked skin and damaged skin leads to loss of protection in a sense. And there is easier access for bacteria to actually enter, causing other issues such as infection of the skin, like cellulitis, what we call it, where patients can have redness and swelling and pain and sometimes they might need antibiotics to actually treat this problem. Not to mention, there are also multiple medical problems that may actually affect some of our elderly patients. And some of the common ones are diabetes mellitus. As you know, Singapore is on a war against diabetes because it is a prevalent disease of lifestyle. And as we grow older, it's more common for us to actually develop this. And it's important to actually consider how we can treat these main medical problems, because treating these main medical problems better can also help to prevent foot and ankle issues as well, because foot and ankle issues can be directly related to some of these chronic conditions. Okay, some of the common topics that I'll talk about today will be on plantar fasciitis, or sometimes what we may actually manifest as heel pain. I will talk about Achilles tendon problems, which is a very common condition that some of our elderly patients may face. And of course, ankle arthritis, midfoot arthritis. And then we'll go on to talk about some of the forefoot issues that are quite common, such as bunions and lesser toe deformities. And then we'll move on to talk about calluses, which are basically thickened skins on certain areas of the foot. And then we will move on to some diabetic foot ulcers, something that may be quite common, especially in a population these days in which diabetes can be quite commonly seen. And then we'll move on to foot and ankle fractures. Since this is the Osteoporosis Festival, I think we should also talk about some of these common foot and ankle fractures that can affect the elderly as well. Okay, moving on to plantar fasciitis, which is heel pain essentially. So what is plantar fasciitis? So as you can see in the diagram, the red area that you can see is where there's some inflammation and redness, and patients usually complain of pain at the bottom of the heel. And it's typically and classically a pain that is very severe in the morning when they wake up. And then it usually gets better as the day progresses. But sometimes if the condition is quite advanced, sometimes the pain doesn't really get better even as the day progresses. But when it starts, it usually starts off as pain in the morning. And it also can manifest as pain. And I see this quite commonly when patients sit down for a long time in front of the computer, especially now with work from home, and then they get up and suddenly they feel pain in the bottom of the heel. Yeah, why is the pain coming on the bottom of the heel? So the reason for this is because of tight calf muscles actually. Okay, it's maybe a bit difficult to understand why a tight calf muscle can cause pain at the bottom of the heel. After all, isn't it a very fast structure? Like, your calf muscle is where the calf is and your heel is where your heel is. I mean, they are distinct structures. But the calf muscle is a very important structure that affects our walking. And what happens when it's tight is that there's a lot of stresses that goes on the foot essentially. And this will manifest as usually pain at the heel because of a tight calf muscle. As you can see in the diagram below, when a person walks, the first step that they take is the heel strikes the ground first. And then the foot becomes flat, as you can see in the second diagram. And when the foot becomes flat, the ankle joint actually rolls forward. As you can see here, the ankle joint will roll forward. And then as the ankle joint rolls forward, the body is moving forward above. And then to follow your body, your foot has to push itself up from the front. And that's how the walking cycle is done. But if you imagine someone having a tight calf muscle, if you look at the second stage, where the foot becomes flat and the ankle is supposed to roll forward, the ankle doesn't roll forward so well because, as you can imagine, the calf muscle is behind the leg here and it's tight. So it actually prevents the ankle from moving forward. But your body is moving forward and your feet has to follow. So what you tend to do is that you put a lot of pressure on the front of the foot to compensate. And that leads to a lot of stress at the bottom of the foot. And that causes the plantar fasciitis that usually happens like this. And that's how a tight calf muscle essentially can cause plantar fasciitis or heel pain. So how do we remedy this? I usually tell my patients, stretching is your friend. And it is successful in 70% of patients. And I like to tell them, it's like brushing your teeth. You brush it in the morning and you brush your teeth in the evening before you sleep. So you need to stretch in the morning when you wake up, and you need to stretch also before you sleep. And that's the best way to actually prevent plantar fasciitis from limiting your life. The other thing is that if you're doing exercises, try to stretch before your exercise begins and also stretch after your exercise is finished. I mean, a lot of people tend to forget to stretch after their exercise because, they feel that they are doing the exercise, they're putting aside time for it, but after their exercise, they need to go and do something else because everyone is has a tight schedule these days. But do not forget to stretch after your exercise, because if you stretch after your exercise, your muscles are already warmed up. And when you do a stretching after your exercise, you actually help your muscles get stretched even better, and that can even cure your plantar fasciitis problem. So this is why a tight calf muscle can essentially cause plantar fasciitis. And I also noticed that a tight calf muscle is very common in patients with a bit of a low arch flat foot and also high arch patients. And this is usually due to the biomechanics of the foot itself. Okay, now moving on to the next common problem that we see in elderly patients, Achilles tendon problems. So as you can see, the calf muscles actually originate from the back of the knee, and they cross the knee joint and actually also cross the ankle joint at the bottom, and they become the Achilles tendon. And the Achilles tendon is the strongest tendon in the body, and it actually inserts into the heel. Okay, what is important to understand about the Achilles tendon is that the Achilles tendon can usually have pain at the point where it inserts into the heel, and it also can have pain sometimes just above the point of insertion at the heel. So we tend to call these two problems insertional Achilles tendon problems, where the insertion of the Achilles tendon in the heel, where the bone is painful, and sometimes the pain is slightly above the insertion, and that is non-insertional Achilles tendon problems. And why do these problems happen? As I was mentioning previously, the Achilles tendon, as we age, loses collagen type 1 fibers. And if you remember, I did say that collagen type 1 fibers is important for the flexibility of the Achilles tendon. And as we age, the flexibility decreases. And basically what happens is that the elasticity also then becomes decreased and becomes a stiff structure. So I like to tell my patients, it's a difference between a cooked strand of noodle and an uncooked strand of noodle. And as you know, the uncooked strand of noodle can crack easily, it can injure, it can break. And similarly, the cooked strand of noodle is more flexible. So that is essentially how we can visualize the Achilles tendon as we age. So the risk of rupture of the Achilles tendon, therefore, is usually higher, especially in patients above the age of 50, especially when they're doing explosive sports such as badminton or squash, tennis sometimes, where they actually have to lunge forward to hit the ball. And the lunging activity itself is an explosive activity where you're using your muscles. And sometimes the Achilles tendon is stressed so suddenly that it actually ruptures. And it's not uncommon that some patients actually hear a pop sound sometimes, and then they find that it's painful and they can't walk anymore. So I sometimes get patients like this, and it's not very uncommon. Okay, so as I was mentioning previously, as you can see in the scheme here, this is an example of an insertional Achilles tendon problem, where the pain is really where the bone is, where the Achilles tendon is inserting. And many times the patient comes complaining of pain at the bone, and they are saying that they can't walk and they can't tiptoe. When they're walking up the staircase, it's painful. Yeah, so many times, sometimes this problem is not just because of the Achilles tendon itself, but there is also an extra bone growth at the heel, right over here, that is usually rubbing on the tendon, and it causes pain as well. So it is important for the doctor to usually assess you with some x-rays and maybe even an MRI scan to actually determine if this bone is actually the cause of the problem. Because sometimes if the bone is the cause of problem, we can actually try physio still, and we can actually try stretching exercises to help the pain, or give medications to help to ease the pain. But sometimes if physiotherapy doesn't seem to work, and if let's say the pain is still present, we may need to take out that bone that is actually pressing on the Achilles tendon. Okay, but sometimes the pain may not be actually at the insertion of the Achilles tendon. It can actually even be, like you can see in this diagram, above the Achilles tendon insertion. And this is what we call non-insertional Achilles tendinitis. So non-insertional Achilles tendinitis is a slightly better problem to have, because most patients with non-insertional Achilles tendon problems tend to get better with physiotherapy, stretching exercises, some medications, at most sometimes an injection of what we call biologics, which is basically your own body's blood, which we actually take out some of these good substances, healing substances in your own blood, and we actually inject it around the tendon to actually help the healing. So some things like called PRP, we call it platelet-rich plasma injections, has been shown evidently to actually help non-insertional Achilles tendon problems. Now, the other reason, other than the loss of collagen type 1 fibers that affects Achilles tendon that I was mentioning about, the other reason why Achilles tendon problems happen at the areas that I mentioned is also because of the blood supply of the Achilles tendon. As you can see in this image on the right-hand side here, this shows the blood supply of the Achilles tendon. And you can see that there's an area here between the green and the yellow where the blood supply is relatively poor. And usually when the blood supply is poor, there is lack of oxygenation, or oxygen in these tissues are poor. And when there is no oxygen in these cells, the cells tend to degenerate. And that's also one of the causes of degenerative problems of the Achilles tendon as we grow older. So blood supply is important. And that's also why commonly patients with diabetes, where the blood supply is affected in diabetes, because in diabetic patients, the vessels, the small vessels are affected by the diabetes, they tend to have a higher chance of developing Achilles tendon problems. Okay, so as I was mentioning before, what can we do for patients with Achilles tendon problems? So we can always try physiotherapy, stretching exercises, and there's also the physiotherapies these days, they also have some access to shockwave therapy, which is basically a gun that emits shockwaves that helps to heal the pain that patients may actually feel at the Achilles tendon area. It does this by breaking down some of these degenerative calcific deposits at the Achilles tendon that is responsible for the pain generation. So that's how the shockwave therapy works. And then if actually the physiotherapy fails to help, the exercises, stretching exercises fail to help, then as I was mentioning, PRP, or biologics in a sense, where we take blood from your body, we spin it, and we take certain part of your blood that is rich in some of these healing substances, and we inject it at the Achilles tendon to help the healing. Now, of course, surgery is always a last resort. And as I was mentioning, sometimes when there's a bone structure that is causing some friction at the Achilles tendon, we may need to remove that bone structure. As you can see in this particular diagram, this is an example of this bony structure. Can you see over here the abnormal prominence of the bone at the heel? And that is usually rubbing on the Achilles tendon. And as you can see in this intraoperative scope image, there's this bony area here that is rubbing on the Achilles tendon right over here, causing all these areas of inflammation. So the surgery can be done by a keyhole surgery, where we put in a scope through a very small incision, maybe about 5 mm incision, and then we actually use another incision, also 5 mm, and then we use a certain instrument to just shave off that bone, using these very small instruments, and that will actually help the patient's pain quite well, especially if the bone is the cause of the problem. Okay, then moving on to another common issue that elderly patients may face is arthritis. Okay, as you can see, the picture on the left is showing the ankle joint. And this ankle joint, the cartilage, you can see is so nice and white, it's pristine. It's like, it's like basically a shiny white cartilage. And that's the way the cartilage should be. That's a healthy cartilage, because the cartilage is like soft bone. The function of the cartilage is to absorb shock, and is also to give lubrication to your joints so that your joints can have good movement. However, as we grow older, what possibly can happen is that the cartilage can undergo wear and tear. It becomes thinner. And it can also be more common, especially in patients who have got previous ankle injuries, like a very bad ankle sprain in the past that was neglected, or maybe perhaps an ankle fracture in the past that was neglected. So what happens when an ankle fracture is neglected or an ankle sprain is neglected is that the joint biomechanics, that means the movement of the joint, is not so stable anymore. That means there's always an excessive movement of the joint because everything is not in the right area. And because it's not in the right area, it's not functioning properly. So there are abnormal areas of high pressure, and that high pressure can lead to accelerated wear and tear of the joint. And eventually that leads to osteoarthritis. Now, this is similar to the osteoarthritis that we know about that can happen in the knee, and it can also happen in the hip, which is very more common areas actually that can happen. But don't forget that it can also happen in the ankle. And in the ankle, most of the time, it is usually because of a neglected fracture in the past. They may not feel the symptoms then, but after many years, maybe 15 years, 20 years, that's when the symptoms start to happen. And this is an example of a patient who may have ankle arthritis. So you can see that the right ankle is swollen, it is red, and the patient complains of pain on walking. And sometimes if the arthritis is very advanced, there can even be a deformity of the ankle. And as I was mentioning, most of the times these problems are because of previously untreated fractures of the ankle or previously untreated ligament injuries of the ankle as well. Another common problem that I see in elderly patients is what we call midfoot arthritis. As you know, the ankle joint is at the hind foot, that means at the back of the foot. However, at the front and the middle of the foot, there is something called the midfoot, and it's made up of many bones at the midfoot. And sometimes this midfoot can actually give pain, and can be wear and tear of the joint. It is usually because of abnormal biomechanics of the joint. Sometimes it's because of a previous injury as well, like a ligament injury of the midfoot. And oftentimes a tight calf muscle can actually make the pain of the midfoot worse. So how can we treat midfoot arthritis? So essentially, the first thing that we usually try for patients with midfoot arthritis is that we try to aim for modifications of the shoe wear. Because oftentimes the midfoot arthritis gets worse, especially when patients wear shoes that are too flexible. And when it's too flexible, what they actually are doing when they are walking is that they tend to use a lot of the midfoot joint to actually push themselves up. Because when your footwear is very flexible, it is not providing you the support that you need to actually push your foot in forward to move or walk. And therefore, we need to actually advise them to actually wear firmer sole footwear, which is less flexible, and it gives them the adequate support that's required for propulsion of the foot. So that is a first thing that we try. And of course, we also give them advice on calf stretching exercises, because a tight calf muscle can usually make the pain worse. And that stretching the calf muscle can help the pain get better as well. Of course, if all these measures don't seem to help, sometimes they may require surgery. And the surgery is usually what we call a midfoot fusion, where we actually fuse the joints of the midfoot. That will relieve the pain, and usually not to worry, because the midfoot fusion where we fuse the joints doesn't mean that you cannot walk anymore. You can walk very normally after that, because the midfoot joints, as a form of design itself, there are not much movement in the midfoot joint, so they are actually very stiff joints to start off with. So if you fuse a stiff joint, you don't really have much. You won't feel any worse. In fact, you will feel much better. Of course, but surgery is still a last resort in many patients. We always try conservative measures first, and then if that doesn't seem to work, and if the problem is very advanced, then surgery is definitely the solution. Okay, going on to something very common. I'm quite sure many of us have relatives or have friends, and maybe even some family members who may have bunions. And sometimes, and more very commonly, I see bunions running in families. And essentially, bunions may not be painful in many patients, but after some time, usually because of ill-fitting shoe wears or just generally the worsening of a bunion can actually make pain become slightly worse for patients. So there comes a point in time where, even normal walking becomes very painful because there's a prominence of the first toe, and that is usually rubbing on the shoe. And patients usually have a very difficult time finding proper shoes to wear, and they need to change shoes very frequently because the shoe gets worn out quite fast. And the problem with bunions is that if the bunion becomes worse over time, sometimes it actually even affects the second toe as well. As you can see in the photo on the bottom, the second toe is already like climbing over the first toe. And I have a lot of patients who actually ask me, okay, when they come with this kind of a problem where, they have a bunion and the second toe is climbing over the first toe, they seem to think that the second toe is climbing over the first toe because the first toe is just very bad, and that's why the second toe is climbing over. But actually, what is happening is that the problem is actually happening on both toes. Both the first toe and the second toe is actually developing a problem. So it is important to understand why. Now, when you have a bunion, what is happening essentially is that your bone is deviating outward. It's actually not a growth of a prominence. It's not like an extra bone that is grown there, actually. No, it's not. As you can see in the X-ray here, actually what is happening is that the bone is actually shifting outside. It's actually coming out of its usual joint. The bone is actually supposed to actually stay in this joint over here, but it's actually shifted outside. Now, that is actually causing the bump that you see. It's not an abnormal growth of a bone. It's a deviation of a normal bone. But the deviation of the normal bone actually causes a change in the biomechanics of your walking. Because what happens when a bone is not in the right position is that the joint is not doing its work, and the function of the big toe is to bear the weight of your body. The big toe is larger size than the other toes. The other toes are small size. The big toe has to be big because the function of being big is that I can support more weight on the body of the body. But now, if my big toe is deviated, what that means is that I'm not supporting my body weight properly because my joint is not in the right position. So what's happening is that the smaller toes, the second, third, fourth, and fifth toes now have to do extra work. But they are not designed for the extra work because they are smaller bones. So what is happening on your second toe especially is that the second toe, the underneath of the second toe where the ligaments are actually undergoing wear and tear. So because of the reason why the second toe is undergoing wear and tear due to this abnormal biomechanics, is your second toe then floats upwards because of the damage on the underside of the second toe. And that is something that I explain to my patients because they need to understand that when they come, when the first toe is deviating and the second toe is crossing over the first toe, it actually is a point where the second toe is also damaged already. So anything that we need to do for them needs to address the second toe as well. And once they understand that, they know that, okay, I need to get something done for the second toe as well. Okay, the other common problem that also our patients face is something called calluses. And what are calluses? So calluses are areas of thickened skin growth. And the thickened skin growth is actually due to increased pressure on certain areas of the sole and also on the front of the foot. And that's where they commonly happen because that's where our body weight is actually, when we are walking, a lot of stress is placed on the front of the foot. And the front of the foot is also where the skin is a bit thinner because, your toes are there, very little soft tissues like fats are there. So generally speaking, whenever there's abnormal pressure, your skin tends to get thicker at that area. And very commonly, this represents some form of biomechanical issues. As I was mentioning, your foot is not, the weight distribution in your foot is not normal when you develop calluses. And it is the duty of the doctor to actually examine you to understand what is happening in your toe. Why are you developing these calluses? Why are your toes getting deformed? Is it because there's some abnormal tension in your tendons, or is it just a general biomechanical problem that needs to be solved? And there are ways to solve this problem. So it's, of course, essentially, the first thing is to understand the problem. we can try some footwear modifications to help the problem, maybe even see a podiatrist to shave the calluses sometimes. And this can help a lot of patients. But if it becomes a recurrent chronic problem, then of course, it's important to understand the root cause of it and to solve the root cause of it. Okay, and now moving on to diabetic foot ulcers. So as I was mentioning previously, diabetes affects the small vessels of the entire body. So that's why diabetic patients have eye problems. They have difficulty hearing sometimes. They have an increased risk of heart problems as well. Why? Because all these organs like the eye, the heart, the kidney, they are all supplied by very small blood vessels, essentially, inside the organs itself. And not to mention your foot and ankle, because your foot and ankle is what we call an extremity. It's at the extreme point of your body. And you can imagine that your heart is like the tree trunk and the main tree trunk. And then from your heart, all the little blood vessels branch out until they go down to your foot and ankle, and they become very, very small blood vessels there. So when diabetes affects you, especially when it's not well controlled, the small blood vessels of the body are the ones affected. So that's why you go for a yearly retinal scan for your eye to make sure that your eye, where the small blood vessels are, it's not being affected by diabetes. And similarly, it's also important for diabetics to actually do their regular foot examination and checks, because you see, diabetes, when it affects the small blood vessels, don't forget it also affects the small nerves in your foot as well. You see, so a lot of diabetic patients, sometimes they cannot feel properly the toes and the feet, and because of the reason they can't feel, when they wear ill-fitting shoes, they have a higher chance of getting injured and not realizing they're injured. They are higher chance of getting wounds and not realizing they have actually got a wound. So self-check for diabetics is extremely important, where they need to check themselves regularly to see whether they are actually developing any redness at any bony prominences or any wounds, open wounds that they may have missed, you see, because they just can't feel. And these are important to note, because sometimes when they have a wound and becomes infected, then it becomes a big problem, because sometimes we may need to do recurrent, repeated small surgeries for them to actually clean off the infection. They may need to take antibiotics for a long period of time. And diabetic problems can become chronic ulcers, and that's what we don't want to happen, because you see, you're walking in your feet all the time and your feet is under pressure, so it also affects the healing of these ulcers. You see, whenever there's pressure on these ulcers, the healing is delayed, you see. So it's not like other areas of the body. When it comes to the foot, you really need to take care. Yeah. And of course, we can give special shoes. We can offer them a certain cast sometimes to actually help to offload the foot so that the ulcers can heal. But prevention is always better than cure, as I like to tell my diabetic patients. So I think addressing the chronic disease or controlling the chronic disease will go a long way in actually preventing the problems of the foot and ankle when it comes to diabetes. And finally, we'll come to osteoporotic ankle fractures. So ankle fractures very commonly also can happen in elderly patients. And when ankle fractures happen in elderly patients, because the fact that they are osteoporotic, they don't need much force to break their bones, because their bones are already they are not so dense. So even a simple chip or a simple ankle sprain can sometimes fracture the ankle badly. And not to mention, whenever it's elderly patients, their skin condition, as I was mentioning before, dry skin, their skin condition may not be very good. So they have a higher chance of getting, when there's a swelling or let's say a dislocation of the ankle, sometimes the skin is is under a lot of tension, and part of the skin may actually die, because when the skin is under tension, there's less blood flow at that area, because everything is so tight and the blood cannot go through the skin, and the skin becomes like a bit unhealthy, and it can actually die, and it can cause some skin problems. So it is very challenging to treat these problems. And of course, most often some form of surgical treatment is required for these patients. and it usually takes a long time to heal. And it's very common in patients who are female, a little bit obese, and also diabetic patients. Okay, so some of the suggestions, I will need to wrap up quite quickly. So some of the suggestions that we can help to prevent foot and ankle problems is be aware of the comorbidities and possible complications, as I was mentioning, diabetes. And as I said, age-related problems such as muscle loss, loss of collagen can be solved with strengthening, stretching exercises, and dietary modifications, and shoe wear modifications, self-examination, and prevent dry skin. Okay, and of course, important to wear footwear that is fitted to you properly, because if it's not fitted to you properly, you can actually develop pressure ulcers, pressure points where there can be problems happening from there. Look out for swelling and pain in the joints. Don't remove corns and calluses yourself. Always visit a professional. And remember, if you're diabetic, warm water to wash your feet daily, that will be good. And also to self-examine. Dry your leg completely and moisturize. And when you trim your toenails, trim it straight through the top and don't cut it at the angle, because that can lead to like ingrown toenail problems, as you can see on the picture over here. Check your bone mineral density, calcium and vitamin D supplements. Dietary change is important, and lifestyle changes. I showed this slide to show you blue zones. So blue zones are basically where there are longevity hotspots in the world. And you can see there are three main areas like Loma Linda in the United States, Sardinia, and of course, Japan, Okinawa. And what is common among these places is that, as you can see, they actually have good family social connections, no smoking, they have a plant-heavy diet, constant moderate physical activity, they are always in some kind of social engagement, and they tend to eat a lot of legumes. So that's very common among all these areas, something that we can take note of. Okay, thank you very much for the attention. I'm going to take some questions now. Okay, let me look at some of the questions. Okay, so someone has asked me whether loss of collagen type 1 fibers does it apply to all other joint areas in the body? Yes, it does actually. So loss of collagen type 1 fibers applies to every part of your body. So it's not only just your lower limb, it also affects your upper limbs as well, and your neck areas, your spine as well. So that's why our spine can get stiff as well, and we can actually develop problems in the spine. Usually the areas that tend to give problems are the areas that are taking a lot of load of our body. So like your foot and ankle, that's why I said the calf muscle, we are walking on it very often. So that is a very important tendon. And of course, the spine as well. The spine, the neck, the back, these are areas that support our body throughout the entire day sometimes. And so a good posture is important. Core strengthening is important, because that will help to prevent your posture problems and degeneration of the bones as well. So yes, it applies to other areas of the body. So Jolene has asked also, why is there a pump bump on the heel? If it doesn't subside, need to go for treatment, or we can leave it alone. Yeah, so as I was mentioning, the pump bump on the heel is something called a Haglund deformity. And if it does not subside and you do not have any symptoms of pain, it's still fine. You can still go for physiotherapy. But if you have symptoms of pain, what you can do is that you can actually try to wear a heel raised shoe. That means try to wear something that raises like an insole or a cushion support at the heel that raises your heel slightly, because that can relieve the tension on the bone, the Achilles tendon on the bone that is growing there. Yeah, I mean, you can leave it alone if it's not causing you problems. You can try these methods. Of course, if it's causing you pain, there's swelling and redness, then maybe, it's good to go for a check. Let's get an MRI scan, see what's happening. And sometimes a small minor surgery may be all that's necessary to actually relieve your condition. What kind of stretch exercises can we do to prevent plantar fasciitis? Yeah, so I would say calf stretching exercises. So something very simple, like, you can put your hands on the wall and then just stretch your calf muscles. Just put your leg at the back, keep your knees straight, and just stretch your calf muscles. Simple exercise like this. And you can even use a towel, and you can use a towel on the foot itself, and then you can pull on the towel just to actually get some dorsiflexion of your heel like this, and that can actually help to stretch the calf muscle as well. If my calluses are due to walking, what can I do to prevent recurrent calluses? Yeah, I mean, you can try better shoe wear, something that fits you better. Nowadays the podiatrists, can give you, like, we call it metatarsal pads. They have got increased cushion on the pads. That can actually help to prevent recurrent calluses. Sometimes the podiatrist may actually also maybe try some, we call it a salicylic acid, which is a lotion that can help to actually reduce the callus. That can be done, and they can even shave as well. But yes, if it's due to walking, I think essentially it may be good to see a professional, like either an orthopedic surgeon or a podiatrist, to see whether the footwear that you're wearing is actually tailored to you, or some modification may be required to actually help you get better footwear. And don't forget, sometimes even calf stretching exercises can actually help to reduce the pressure on the front of the foot. So calf stretching can actually also prevent calluses in a sense. Okay, how to prevent the deviated big toe from getting worse? Okay, you can, how you prevent the deviated big toe from getting worse? You can have the bunion correctors that you can buy commercially over the counter. That's one way you can actually help the big toe from getting worse. But does it work? Unfortunately, in my experience, I feel that it doesn't work so well. I mean, it helps you to fit into your shoes better, definitely. But I mean, it doesn't prevent the problem from actually going through its natural cycle and getting worse, because essentially bunions are because of a deviation of the bone. And when you keep walking on a deviated bone, the bone will just deviate more. So the biomechanics is altered already. And therefore, it is essentially an irreversible problem. It cannot get better. But you can try to do calf stretching exercises again to reduce the stress on the bunion. You can also use bunion correctors to actually help to correct it and wear better shoes for it. And essentially, that's all you can do to help it from getting worse. I mean, you can control it from getting worse, but you cannot reverse back the bunion, unfortunately. Okay. Yes. Okay, the bunion operation is how long? It depends. So it depends on how bad the bunion is, and does it. I mean, if you are talking about just a pure bunion operation, the pure bunion operation on the bunion itself is usually, if a minimally invasive surgery, is about 1 hour. If let's say an additional procedure needs to be done, it can be about 1.5 hours. So that's how long it is, but it really depends, and it's better for it to be assessed by a professional, or you can see me, and we can do the necessary investigations and decide what needs to be done.
Okay, thank you, Dr. Anandakumar, for your most enlightening presentation. And thank you, viewers, for joining us at this session. For more inquiries, you can contact Dr. Ananda. His email is ananda@cfo.com.sg. Okay, do check out our other webinars today. For other inquiries, such as a bone mineral densitometry or DEXA scan, contact SATA ComHealth's hotline at 6244-6688. I repeat, 6244-6688. Thank you so much, Dr. Anandakumar, for your talk. And I hope to see the rest of you at our webinars later today. Thank you very much.
Thank you, Edmund.
Thank you, Dr. Ananda.
Thank you.